So now let's move on to our next speaker. So welcome Jane Shrapnel, who's going to talk about eMR Analytics Data Warehouse, an avenue to electronic clinical registries. Thanks, Jane.
Thank you. So do I have control of the mouse? Okay. I do. Okay, great. How do I go back? How do I go back on this? Sorry, guys.
Hi, Jane. Feel free to use the arrows at the bottom of the...
that way. Perfect. Thank you so much. So my name is Jane Shrapnel, and I am a data scientist at the Sydney Children's Hospital Network, and I wanted to talk to you about how we're setting up an analytics data warehouse that can be used for electronic clinical registries. And before I start, I just wanted to begin by acknowledging the traditional owners of the land in which we meet today. I would also like to pay my respects to the elders past and present. Okay. So, I don't think I have control of the mouse, but there we go. Okay, so at SCHN, at Sydney Children's Hospital Network, we wanted to build a data warehouse that is using the eMR data to improve patient care and hospital efficiencies. So we've had quite a big, ambitious goal to make use of all of the data that's in the eMR. So I wanted to take you through that journey today and hopefully give you some ideas about how you can use that information in the eMR to develop your own registries. So for us, I know this is quite a technical document, this is what we're aiming to build. So basically we've got the eMR production, we've got a copy of that, we've developed some, we're building out the extract, transform and load tool and building the tables in the analytics database. And then from there we'll build out some specific data marts. So that might be for things like cardiology, or it might be looking at clinical variation overall, and you can look at different diseases within that. And then it can be sent to electronic data repositories for national capture. And then internally, people can access that data internally, either through their own queries or through dashboards. Okay, so just to give you an overview, damn it, got a bit of a lag, an overview of Sydney Children's Hospital Network. So we have two campuses. We've got the Randomised Kids Hospital and the Westmead Kids Hospital. So we see probably a few more patients at Westmead than Randwick, but overall we've got about 100,000 ED presentations a year, 50,000 admissions and over 1 million outpatient services. So it's quite a lot of data that we have across the two campuses. And just to give you an idea of, if anybody has not seen the eMR, what potential information we can collect. So as Charmaine mentioned, there is structured and unstructured data. We focused more on the structured data initially. So we're looking at things like, you've got, also this is taken off the web, so it's not someone's information. So you've got things like vitals, so we can get like a temperature, heart rate. We have height and weight. We've got what medication they were on, what labs results they had. We can get out what documents were written. We've got what diagnosis they might have, what treatment they might have. So it has a lot of information about a patient, obviously not everything that you wanted to know, but quite a bit of information. So for us, we looked at the first challenge of how do we want to access this information. And for those of you who have requested information from the EMR, it can be quite a slow process because it requires a specialised skill to access that data. You can't do complex queries on it because it will cause delays on production. And you can't easily aggregate data flows to external data sources or create visualizations, and it's often not in real time. So what we wanted to do was kind of work out how we can solve that first problem and get to a state where we can easily extract data from the EMR and put it into reports, national repositories, or use advanced analytics to integrate back into real-time decision making. So the way that we did this was to use a mirrored copy of the EMR. So this is a real-time copy. So when clinicians enter data, so say a heart rate, then this will update into the mirrored copy at exactly the same time. So we can have access to real-time data and query that data as it's happening, which is great. It means that we can access really large amounts of data, so we can extract millions of records and it won't impact production. We can do complex queries, which will be looking across multiple tables, which also won't impact production. We've had some reports that have been built in CCL, which is the Cerner command language, that haven't been able to run because they're too complex. So we've now been able to run those queries. So now that we've accessed the data, now what? So if any of you have seen the eMR data, the Cerner table structure, it's a data lake. It's completely unstructured for extracting information out of it. We also, it is a lake, and it's like, where do we start? What do we look at? So we were thinking that we've got to talk to people, and we've got to understand, what do clinicians want? What are the kind of research areas that people want to look at, or what does hospital want to improve at? So we engaged universities, research executives and clinicians to ask them what they thought was important. And we also didn't have any idea about data quality or what are the business rules that impact how data is entered. So obviously having two hospitals and having different departments, that one department might input data one way and another department might input data a different way, even though they're the same medical function. So understanding those kind of things as well. So from those talks, we decided that we would categorize the different use cases into different areas, and this will help us structure how we wanted to define the tables. So for us, looking at, these are just examples, and it's a not exhaustive list, but these are the common themes that came out, that we want to look at chronic patients, so long-term patient outcomes, where you want to look at how many times someone's visited, how many outpatient appointments they've had, and you're looking at a space of over years and what are their outcomes over years. And then you're looking at things like clinical operations or clinical variance, and particularly for clinical variance, it's often can be at an acute level, and so you want to know what time medication was given, what the outcome of that medication was, and it's really down to the minute, hour, and it's much more about, diagnosis, pathology, medication and treatments in that acute episode of care. So this helped us kind of think about how we wanted to structure data so that we could allow anyone to come to us and say, we've got this particular disease that we want to look at, or this particular patient cohort we wanted to look at, and we could look at the different ways that we structure data and say, okay, it fits in this way, we can get this data out for you to help you with this. So some examples that we've looked at, which I'll run through, is looking at clinical operations, of can we reduce the length of stay for febrile neutropenia patients, which are cancer patients with a high temperature and a low white blood cell count, so they are at risk of adverse outcomes. So we were investigating if we could put in a new model of care for that. The other one we've looked at is, can we use the eMR for rapid surveillance and alerting of deteriorating conditions such as sepsis? So I'll run through how we've done that. So this is the way that we've set up our processes to deliver value back on clinical analytics projects. So we've engaged with the clinical team, selected the cohort of patients using eMR data. So that might be ICD-10 codes, or it might be vital signs or pathology results. So that was determined by the clinical team. Then we've, as you would normally do, develop a kind of a minimum data set or what data you want collected. How this differs from the usual project is that we would go to the eMR and we would match up and source that data in the eMR. And then in some instances, we might say, look, we don't know, we don't want to look through notes, so we don't want to look at someone, say, that's dehydrated and see if it's written in the notes, but perhaps we can look at what treatment they were given, or something like that, and that can be used as a proxy for someone that's dehydrated. And that was tested and agreed by the clinical team as well for those kind of examples. And then we set up data workflows so that we could create the first data set, and then it will be an ongoing data set. So we just, each time we want to get more data, we just run it and it can run. And then we conduct the analysis and develop any clinical tools that will support clinicians in their decision making. So the first one we looked at was the one I discussed before. Can we use the eMR to rapidly validate international clinical decision rules to risk stratify febrile neutropenia patients into high and low risk? So there had been a lot of research done in this area already. So what we did was look at two of the main clinical decision rules that had been validated, built and validated, and look at validating that using eMR data rather than a research nurse. So what we did was set up our data flow. So we developed a way of categorising someone as clinical description of severely unwell. So that was using notes, and that was working with Charmaine's team. So doing a similar kind of analysis to what they did in the cardiology space. And then we looked at things like total white cell count, temperature, hemoglobin, monocyte count. So that kind of information is quite simple once you know where it is to get out, and we were able to understand how that might be recorded, what time that it was recorded, which dates to use, and then looking at also cancer type and preceding chemo as well. So that required a little bit of data engineering because cancer type is unfortunately free text. So we just have to categorise that based on the different ways that someone might write, AML or acute myeloblast leukemia, which is exactly the same thing. So what we did was apply this CDR on the eMR, and we went with the picnic rule because that was the most accurate for us. So we looked at 237 patients over a yearly period, and 29 of the outcome variable was if they had a microbiologically defined infection, which would be an infection in their blood. And we had 29 in the data set that had that. And then when we applied, the first instance was seeing if we had eligibility to apply the rule. So there was 80 in that group that didn't have any morning bloods run. So someone would come into the hospital, they would stay overnight, and then they'd have this algorithm would run. So if there was no morning bloods taken, then we couldn't, the algorithm wouldn't have enough information to run. So that was 157 that were eligible to have the algorithm applied, with 21 of those having an MDI. When we applied the algorithm, 57 were considered low risk and they were eligible for hospital in the home, and 100 were considered high risk. And you can see there that 4 had an MDI in the low risk group and 17 had an MDI. So in the high risk group. So you can see that the algorithm is distinguishing to a certain level of the high risk group, and that's who we were focusing on. Then the next step was to apply the specific HIT criteria for oncology patients. So this is looking at things like, are they new diagnosis? Do they live close to a hospital that they could come back to? Are they high risk cancer patients? Someone with a brain tumour might not be sent home. So going through that, and then we went through that criteria. 44 were eligible for hospital in the home, and 1 had an MDI, and 13 were not eligible. So the one that had a microbiologically defined infection, that was picked up that afternoon. So they would have been brought back straight away if they hadn't been sent home already. So we did some calculations on this, and if we applied this model of care, it would mean that a cancer patient with febrile neutropenia would come in, stay 24 hours. If they're eligible for the HIT program, it means that they would be sent home to hospital in the home and be treated at home for approximately 4 to 5 days, and this would save $700,000 a year for the hospital and 0.5 bed days. So we're just looking at implementing that now. So this will be an automatic workflow through to the eMR. So when a patient that met the criteria, when a patient came in and they met the criteria in the morning, an alert would pop up for the clinician, for the oncologist, to say that this person meets the criteria. To be considered for HIT, please go through the specific HIT criteria. And I should also mention that Peter Mac and Royal Children's Hospital in Melbourne has implemented this already, so they've been really great in assisting us in this process as well. So another project that we looked at was reducing variation to provide high value care. So this was a New South Wales state-based initiative, but so initially when they came to us, they wanted to do an audit of 20 cases. And so we kind of turned around and said, look, we can actually get every single case of patient. So we want to look at that and see how we can use that information rather than doing it in the traditional way. So this case was looking at bronchiolitis patients, and this is something that affects children below 2. So, but it's quite a common disease for children. So there is about 1,500 bronchiolitis patients that present to ED each year, and this peaks in the winter period. And because it presents similarly to things like wheeze or pneumonia or croup, it can be sometimes difficult to diagnose accurately, and so this factors into the variation in care. So what we wanted to look at was how we can standardise some of those practices. So we got out all of the data, we've analysed it, we looked at, we were able to categorise them by low, moderate and severe bronchiolitis. And what came out of that study was that we were probably overprescribing MPAs, and we also weren't very good at weaning children off oxygen and discharging it at an appropriate time. So working with the clinical teams, they looked at the research at what time you could safely discharge a patient once they've been off oxygen, and there wasn't any research that was out there. And I think Royal Children's Hospital was discharging people after 4 hours, and we were discharging people after 6 hours. So we moved to do that. And so we developed a dashboard to help the clinical teams to kind of track how they were going with this new initiative that they wanted to put in place. And we were able to help them decrease the amount of time that kids were discharged from oxygen cessation. So from the new protocol was implemented in April, and then you can see in May, June last year, they were able to reduce up to 4 hours, and this continued on through the rest of the year. So they were able to keep up this practice, and we're going to continue it this year and see if we can. This was implemented at Westmead, so we wanted to see if we can implement it at Randwick as well. The next project that we're working on is looking at how we can identify and treat sepsis patients, suspected sepsis patients in ED. So what we want to do is put in alerts for the clinicians so that for any patient that may be missed when they're in ED, an alert will pop up that will either identify the patient as suspected sepsis, or it will encourage certain tests to be ordered. So at the moment, we're working with clinicians about what these alerts will look like. And the alerts that I have up in front of you are based in Western Sydney, Westmead Adult Hospital. So they've developed these already, and they're helping us through the process to develop a paediatric centric ones that we'll be able to share with the state once we've developed them. So for us, the hardest thing has been to define what actually is suspected sepsis and what is sepsis, because it's obviously not something that is necessarily a diagnosis. So this has probably been a year-long analysis to actually define who is confirmed having sepsis and who is suspected of having sepsis. And there is also an international committee working to develop the paediatric sepsis 3 definition at the moment. So we've tried to be in line with the work that they are currently doing, however they haven't released their final findings yet. So we'll obviously edit them when that comes on. But we've been able to look at being able to calculate the organ dysfunction score, failure score. So it's quite a complicated score, so being able to automate that and be able to calculate that saves a lot of time for people. So looking at someone that has an organ dysfunction over 1, we can see that this person was able to sorry, I've lost what I was saying. We've been able to calculate this, and rather than having someone sit there and the research nurse kind of put that into a calculator and say, okay, this is what this is, or put it into an Excel, and that's done. So it's done in an automatic way, which I think is really helpful. We've been also able to look at blood culture positive. So that's quite complicated because it's a text. So we've had to do a lot of the work that's similar to what Charmaine has done, is work out different types of way that that's recorded, and to say, okay, this person's positive, this person's negative. And then also looking at whether they've gone to ICU or some of their lab results. So as an initial, and we've tested this with the clinicians and what they and their thoughts on the numbers, and I think that they're comfortable with the definition, that it looks reasonable. It could be a little bit low on who is high risk and who is confirmed sepsis, but at the moment this is what we're going to go with. And then in terms of alerts, we've worked with clinicians to say, the senior clinicians, if someone comes in, what do you think are good criteria that would alert you to this person being suspected of having sepsis? So they've given us different things. So someone that has a high low temperature and they're 28 days old, or high low temperature and they're 90 days old, and how many of the people in the cohort actually meet that criteria. So this can inform potentially what alerts we'll put in. So temperature in the central line is often oncology patients, and 63% of those patients meet the criteria for high risk or confirmed sepsis. For that cohort of groups, we have a quite clear protocol and guidelines. So it probably won't be that helpful in terms of determining who is suspected sepsis that we might be missing. What is a bit more interesting is we looked at tachycardia for 20 minutes or 60 minutes. So the guidelines state for sepsis, someone that has persistent tachycardia, it doesn't actually define what persistent tachycardia is. So we've looked at 20 minutes and 60 minutes to see which one yielded better results. And they're quite similar. So the 60 minutes is a little bit more at 10%, and also looking at signs of toxicity, because that's key for identifying children that have sepsis. So we're at the moment working through these different alerts that we could potentially put in that would help junior clinicians identify these patients. Another one that we're working with, which I think is an interesting example, is determining the appropriate use of antiemetic medication to prevent vomiting post-op. So this is a clinical indicator for anesthesiologists, and the research is quite clear, but they were hoping to develop something that will give them a bit more confidence in which direction they should go in. So if they're given any opiates or any pain medication, generally they should always give them an antiemetic. In case they weren't, or in case something happened, they wanted to have an automated tool that would come up and let them know the probability of someone vomiting, or if they're having fluids, or what kind of anaesthetic they were given, and the surgery type would also influence whether they vomited. So this case was, the reason why this was interesting is because we didn't actually have the outcome variable that does a patient vomit. So we used whether they were given odentatone afterwards, which is an antiemetic medication that's commonly used in this circumstance. But when we presented this results to the whole department, there was some concern that that wasn't an accurate way of determining if someone vomited or not. So we've gone back to the nursing unit, and we're looking at ways that we can put that information back into the eMR so that we can be sure that we are actually capturing the correct patients. So I think with this example, it's good because it shows that while the eMR does capture a lot of things, it doesn't capture everything. And if there is something that you would like to capture as part of your clinical trial, you can often put that in as a form or in an extra section of the eMR if you can discuss it with that team. So just because the eMR doesn't capture that information doesn't mean you can't request to put that information in the future. So keep that in mind when you're looking at clinical registries. And that is the end of my speech. I just wanted to acknowledge Paediatria funding, part of this project, and the University of Sydney Centre of Translational Data Science, Paediatric Metabolic Centre, Cancer Centre, and Western Sydney LHD for their assistance in some of these programs. Thank you.
Thank you very much, Jane, for that really interesting talk on how you can use data-driven insights to inform clinical care.